This is Alvaro Alonso. I am an assistant professor of medicine at the University of Massachusetts Medical School. I would like to thank Dr. Walker and the new Cardiovascular Horizons organization for inviting me to this digital education series. I will talk about congenital heart disease in adults. And the focus of this talk is primarily what a primary care physician should know about congenital heart disease. So congenital heart disease is relatively frequent. About 1% of births in the United States are kids with congenital heart disease. So we get approximately 40,000 new children with congenital heart defects. And about a quarter of them have actually severe or critical congenital heart disease that will require multiple procedures. Luckily for them is that neonates have experienced a significant improvement in survival as we look at this graph here, and also the children, of 0 to 17 years of age have also derived a significant improvement in survival. In hospital mortality is much lower these days. To the point that children which used to die or suffer a lot from congenital heart disease are actually now surviving into adulthood. And so this is where now many primary care physicians and many cardiologists will actually encounter some of these patients, to the point that we have over 1 million people in the United States that are adults with congenital heart disease. Currently, greater than 85% of kids survive into adulthood. And you can see in these graphs how the percentage of adults with congenital heart disease actually has substantially increased. Congenital heart defects can be classified in many different ways. One of the most frequent classifications depends on whether you have a blue kid or a non-blue kid. So cyanotic or blue, cyanotic cyanosis-inducing cardiomyopathies include Tetralogy of Fallot, transposition of the great arteries, tricuspid atresia, pulmonary atresia, and other abnormalities of the truncus or pulmonary venous return. There are also a lot of disease processes that don't cause cyanosis, such as ventricular septal defects, atrial septal defects, patent ductus arteriosus, and AV septal defects. They don't cause cyanosis, but they're associated with a left to right shunt. You also have obstructive processes, such as pulmonic aortic stenosis or coarctation or hypoplastic left heart syndrome. And then you have other problems, such as coronary artery anomalies, anomalous origins of these coronary arteries. One that is very frequent, bicuspid aortic valve with or without aortopathy, Epstein's anomalies, and then a myriad of genetic syndromes that may have a lot of these things associated. So let's start with some of these other congenital heart disease. And the most frequent is bicuspid aortic valve and aortopathy. So bicuspid aortic valve is the most common congenital heart defect with a prevalence of between 0.5 and 2% of the population. It can be isolated aortic stenosis, but it could also be associated with other congenital anomalies. The most frequent characteristics is that of patients who develop aortic stenosis or aortic valve insufficiency earlier in life than what you would expect, usually in their 40s or 50s as compared to 60s or 70s with calcific aortic valve disease. And very frequently they have aortopathy, which is a problem with the media of the aorta, which leads to ascending aorta aneurysms and dissection. So in this pictorial, I can show you some echocardiographic pictures of a bicuspid aortic valve where some of the leaflets are actually fused. Sometimes these valves can be fairly defective and lead to aortic insufficiency as well, but they often are associated with aortic aneurysms and eventually even dissections. The things that people should know about is, one is the emphasis on the aortic root dilation, because the majority of 50 to 70 or 80% of patients with bicuspid aortic valve will have at some point aortic root dilation, and they actually may need repair of the aortic valve, of the aortic root, regardless of how severe their valve is. Their rates of aortic dissection are approximately 0.1% a year. I think that things that people should keep in mind is the cutoffs that if an echo or so shows that the aortic root is greater than 4 centimeters in one of these patients, you should consider a CT angiogram to fully examine the aorta, and that aneurysm repair should be considered in patients with aneurysm greater than 4.5 centimeters, which is a much lower cutoff, 1 centimeter less than that of other population with ascending aortic aneurysms. Also, it's important that first-degree relatives of patients with bicuspid aortic valve can also have aortopathy, regardless of whether the presence or absence of bicuspid aortic valve. Now, let's move on to atrial septal defects, which is also fairly frequent. As you know, human babies typically develop an ostium primum and then an ostium secundum, and they typically have, babies have a foramen ovale that allows for circulation from the placenta into the systemic circulation. When we're born, that patent foramen ovale typically closes. Approximately a quarter of the population may have a patent foramen ovale, but also a subsegment of the population may have a hole in the secundum, in the secundum set, and that is actually in a secundum ASD most of the times, which is the most frequent type. You could also have a sinus venosus atrial septal defect, coronary sinus, inferior sinus, or primum atrial septal defect, but the most frequent is right in the middle, the secundum ASD, and then separate topic, patent foramen ovale, which is also in the middle of the septum. So this is an example of an echocardiogram where you can see the aortic valve in the right atrium, which is very dilated, and a secundum atrial septal defect, which is the most frequent type. Now, this one is very easy to close. You can actually put a closure device percutaneously here, and that will actually have sufficient rim to hold it in place. However, other types, for example, primum ASD, don't really necessarily have that rim to allow you to close it. And so those are typically repaired surgically. Although atrial septal defect could be fairly benign for a while, I think it's important to recognize that about a third of patients have an associated malformation, so other things. It's more frequent in females, but they tend to tolerate pregnancy very well. The things that we see is enlargement of the right-sided chambers. And oftentimes, the first signal of AKG will be a right ventricular, intraventricular conduction delay. On physical exam, we were taught of the fixed second sound, which essentially does not vary with respiration in patients with secondum ASD. Few patients may develop pulmonary hypertension, but that's actually rare. And their most frequent problem is actually atrial arrhythmias, which are oftentimes the way they present. Patients that present with atrial flutter or atrial fibrillation. And in fact, those atrial arrhythmias lead a lot of the morbidity and mortality for these patients. The echo is diagnostic. MRI can help you with further characterization. And the guideline recommendation is to intervene and close it whenever there is right atrial and right ventricular enlargement. Currently, most secundometrial septal defects are closed with percutaneous techniques, essentially little umbrellas that have a fabric material that can get deployed across the septum on both sides and essentially sandwiching the hole. There are different models and brands. This is not an advanced interventional talk for that, but they actually have very good outcomes. Other types of atrial septal defects actually need surgical repair. Sinus venosus, primum type ASDs, or whenever you have anomalous pulmonary vein connection, which happens in about a quarter of patients with secondum ASD. Ventricular septal defects also cause shunting, and they do not cause cyanosis. So essentially, they're holes in the interventricular septum, the septum that separates the right and left ventricle. They are called according to the region where they're located, so the most frequent are membranous or perimembranous, which are just underneath the aorta. They're also called inlet, muscular VSDs, which tend to be further down the apex, etc. So a muscular VSD would be right underneath the aorta and very easily identifiable, whereas a muscular VSD will be right somewhere in the middle of the septum or towards the apex, like in this one, right in the apex, and here seen on an MRI. Percutaneous closure could be attempted in many patients, and those are typically most successful in perimembranous VSDs. The things that a primary care physician should know is that the smaller the VSD, typically the greater the murmur. So one may get really scared with a loud murmur, but the reality is that it may be inconsequential. I think another important thing is that the murmur tends to be holosystolic. There tends to be a thrill associated with it on examination, and it tends to radiate almost in a band fashion across the chest. You could have a wireless split-second heart sound. Small VSDs many times close spontaneously in childhood. Depending on the location of the VSD, can affect the aortic valve or other things. And large VSDs result in a lot of shunting, which then can result in pulmonary hypertension and should be closed. Regardless of the size of the shunt, one should understand that this causes a lot of turbulent flow, and so these patients may be at risk of endocarditis. Patent ductus arteriosus. So this is also part of a congenital or congenital circulation, where we have actually a ductus arteriosus that connects the pulmonary artery to the aorta. So it's usually closes at birth. Is very rarely found in adults. It's usually an isolated lesion, and you can hear it as a continuous murmur on examination. Most of these can actually be closed percutaneously and should be closed percutaneously. You can use either coils or other fabric closure, PTFE or fabric material closure devices to close them as well. These patients may develop EISENMENGER'S, where you have more arterial blood or more red blood, if you want to say it that way, in the upper extremities, but because you have shunting from the, here, you could actually develop cyanosis, digital clubbing in the feet. All right, so moving on to obstructive processes, coarctation of the aorta, which can cause or present as suspected hypertension, and oftentimes can also be found with anomalies on auscultation. Sometimes you can auscultate a hum or a continuous sort of bruit because of all this collateral formation, or one can find that a patient has rib notching on the chest X-ray. These patients tend to have a bicuspid aortic valve, the majority of them. It can be associated with Turner syndrome. This is a little more complicated. It's typically corrected with surgeries when they're infants, but patients can present actually as adults. And so these patients need to be followed for systemic hypertension, the presence of bicuspid valve. Sometimes these patients that were repaired as infants or children may have recoarctation. They can develop aneurysms at the site of the operation, etc. If there is renarrowing, we oftentimes do stenting, but that also needs to be decided. So this is an example of a coarctation that actually gets stented. Another problem is Tetralogy of Fallot. So it is the most common one to cause cyanosis, and it has multiple associated anomalies. It's typically a ventricular septal defect with an overriding aortic valve because it doesn't have the support. There tends to be subpulmonic outlet stenosis and right ventricular hypertrophy because of the increased flow. These patients usually have cyanosis and clubbing. There's an RV lift on exam and a holosystolic murmur, mostly at the pulmonic area. Initially, back in the day, and in selected patients these days, there were palliative shunts, connecting different arterials or venous circulation in different ways. Most of the times these days, there is actual correction. So where there is a ventricular septal defect patch, like in this, resuspension of the valve, and then eventually a patch closure of the outflow tract. Now, this oftentimes leaves the patients without a pulmonic valve, and so they have chronic pulmonic insufficiency. And so chronic pulmonic insufficiency over time may lead to right ventricular dilatation and dysfunction, and that can trigger arrhythmias. So oftentimes, when someone sees these patients as adults, these patients may present with atrial arrhythmias and right ventricular hypertrophy. The first transcatheter valve replacements in humans were actually performed in the pulmonary circulation in patients with a previous Tetralogy of Fallot repair. This eventually grew into the transcatheter aortic valve replacement that is now fairly common. Sometimes this is a case report that was published by some of my colleagues this week in the New England Journal here from UMass. So a 29-year-old immigrant who presented with shortness of breath. So one never knows what you're going to find. This patient underwent an echocardiogram and actually had an unrepaired Tetralogy of Fallot. So you never know. Transposition of the great vessels are more complicated. Essentially, is that the ventricles are flipped, and these are much more complex surgical congenital procedures. Then the corrections are there's two ways to correct them. One is flipping the atria, usually with the creation of baffles to direct the flow to the right place, or switching the arteries, which is the arterial switch or Jatin procedure. EISENMENGER'S syndrome is a pulmonary hypertension that is associated with a shunt with reversed or bidirectional flow. It happens in approximately half of the unrepaired significant shunts below the level of the tricuspid valve, so below, in the ventricular septum. But it's very rare that it would occur in atrial septal defects. People with EISENMENGER'S may present with hyperviscosity, and sometimes they require phlebotomy. And they may also present with bleeding and hemoptysis, heart failure, or arrhythmias. And then, because of all this breakdown of hemoglobin, they may actually also have calcium bilirubinate gallstones or hyperuricemia. So I hope this has served as a general overview. I think it's important for providers to understand the basics of these congenital heart defects, because many of these patients may be followed closely as children, and then as they become teenagers or young adults, they may move, or you get lost for follow-up and may present to your primary care clinic. I think another point that is important is, when is endocarditis prophylaxis required these days? So in general, for non-congenital conditions, is any patient who's had endocarditis, or a patient with a prosthetic valve, or with some sort of prosthetic material used to repair the valves, are the patients that should require endocarditis prophylaxis prior to procedures. For people with congenital heart defects, any unrepaired cyanotic disease, or any repaired congenital heart disease with prosthetic material, if it's been within 6 months of the procedure, or if they have residual defects or patches that cannot endothelialize, or patients who have received heart transplant and also have a valve disorder. The ACC/IHA recommendations say that the care should be coordinated by a regional adult congenital heart disease center. I'll show you where you can find some of these centers to assist you in the management. Obviously, your local cardiologists also know how to support you and how to eventually request the care of an advanced congenital heart disease center. And the guidelines actually spend a lot of time encouraging communication with your primary care physicians. There is the Adult Congenital Heart Center Directory, which is not completely inclusive of all the centers with congenital heart disease, but it can give you, it could be actually a good resource to utilize on occasion. So in summary, congenital heart disease could be present in approximately 1% of births. These days, we have significantly improved survival, to the point that we have more adults with congenital heart disease than children with congenital heart disease. Cyanotic heart defects require immediate correction. Acyanotic or obstructive defects, well, it depends on the clinical presentation. There are multiple percutaneous therapeutic advances that may obviate the need for surgery for some of these patients. Don't forget about endocarditis prophylaxis in complex congenital heart disease, and these patients should be managed by in a multidisciplinary care in collaboration with your primary care physician. Thank you so much.